This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1254, recorded on September 18th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
I see a red tie there, Daniel.
It is my Prion bow tie. So I have a couple Prion. This is my orange Prion bow tie. So,
yeah.
All right.
We got a little delay here because I happen to be in Greece and the internet is slow. But your video is blurry, so I had no idea what your tie was.
Okay. I think also what's not helping is the internet in my house has been down for the day, and so I'm using my iPhone as a hotspot. So challenges on either end, but we will jump in, and I'm going to start with my quotation. And I'm certain I have used a quotation from Abraham Lincoln before. And I had another quotation up there, and then I ran across this one. I was like, this is a good one. And here we are, Abraham Lincoln. I am a firm believer in the people. If given the truth, they can be depended upon to meet any national crisis. The point is to bring them the real facts.
Oh boy, what a relevant quote, right?
I ran across it. I was like, that's so relevant. I mean, it's a mixture of there is this optimism, really believing in the people, believing in the potential of the democratic process. But I think really focusing on the fact that the critical thing is you've got to bring people the facts. And right now we're seeing a lot of challenges with people whose agenda seems to be more important than the truth. So, but we're here, and we will keep spreading the truth. So let me start off with this first. The Northeast U.S. states form health alliance in response to federal vaccine limits. Just to read a little bit here. So 7 northeastern U.S. states, including New York, Pennsylvania, and New Jersey, have banded together to form a new public health coalition. I feel really bad, right? They say 7 and they only mention 3, right? Like the other 4 states are like, we didn't make the front line. But anyway, I'll keep going on. They are going to make their own vaccine recommendation in response to the Trump administration's changes to federal vaccine policy. They should just say RFK. I mean, throw the right guy under the bus, right? So the effort, called the Northeast Public Health Collaborative, resembles a similar collective of California and 3 other Western states known as the West Coast Health Alliance, which issued its own vaccine recommendations. Now, in both cases, the coalitions reflect an attempt to overcome federal limits on vaccine accessibility, including for COVID-19 under the leadership of the U.S. HHS Secretary RFK, a vaccine skeptic who they properly, describe. Now, our New York Governor, Kathy Hochul, said that the Northeast Coalition had agreed that updated COVID-19 vaccines should be given to children ages 6 months to 18 years, older children, adults with certain risk factors, adults older than 64. The group also said that all adults are recommended to be vaccinated. As Washington continues to launch its misguided attacks on science, New York is making it clear that every resident will have access to the COVID vaccine, no exceptions, Hochul said in a statement. So really just a lot of this is access, like taking away people's access. And here we have going to apparently expire on the 5th, but then be renewed here in New York State. We have people stepping up and making sure that we have access to the vaccines.
This is great. I'm really happy to see this happening. I just wonder why Vermont and New Hampshire didn't join this Northeast coalition. And it's a little strange. They're in the Northeast and they're not in the group, but it's great.
Yeah, I mean, New Hampshire's a little bit of an outlier. I'm sure we have some New Hampshire listeners. And I was up in Maine, right? And there must be some rivalry going on there because I was looking at the levels of vaccination in New Hampshire versus Maine, and looking at requirements for schools and the rest. And I said, wow, you guys up here in Maine, measles, your vaccination rates are really high, but you've got this big, huge border with New Hampshire. And New Hampshire has like less than 90% for the measles vaccination. Well, what's the deal? And they suggest it had to do with the motto, live free or die. So apparently they're maybe taking that a little too far. Okay. No, nothing harsh meant for the New Hampshire. Keep listening. All right. Now, right now we're in the middle of the 2-day ACIP meeting. So that's today and tomorrow. I expect we'll need to discuss this more in detail next week when there's been some time for the meeting to run its course, for us to digest what happened. But these are not just discussions. There's votes today. It probably already happened by the time we're recording, looking at the MMRV, looking at hepatitis B. And then Friday, COVID, and votes on all three of these. And sort of issues has been discussed before, but we'll see what they discuss about MMR versus MMRV, hepatitis, getting it at birth, and then Friday, COVID. So, but there was a nice,
Daniel. So they're going to vote on the Hep B tomorrow. If they remove the Hep B for babies, I am sure these state coalitions are going to restore it immediately because that's a necessary vaccine. Don't you agree?
So it is. And, forget about their rhetoric. The reality is when we did not give hepatitis B at birth, about a quarter of the cases were still occurring. So, thinking of it the way they think about it, their rhetoric, if you do not protect all the babies being born at birth, you're going to see all these kids ending up with getting hepatitis B. And so that's something that needs to be done. The MMR versus MMRV is like, do you get the vaccine at the same time as part of the MMR? That's been sort of discussed before. It impacts the percent of the time that, there might be seizures. So in the past, there was by the way, MMR without MMRV might be lower. You might consider to separate that. So sort of a bit of guidance, but be curious to see how they dig into that.
Daniel, what did you say the V stands for in MMRV?
Oh, so I'm glad you asked. It's vaccinia, so it's the chickenpox component. And,
okay.
People may think, chickenpox, not a big deal. But prior to chickenpox vaccination, we were seeing over 100 deaths a year from chickenpox, right? So those deaths are preventable. And also, right, you get chickenpox, and then you end up with this dormant virus. And we're seeing a lot of connections now with reactivation and dementia, and then needing to get, the shingles vaccine. And so. All right. Now, in preparation for maybe digesting that meeting, we have some nice information from CIDRAP, the Center for Infectious Disease Research and Policy, out there at Minnesota. Some of my buddies out there. First, the quotation. So ACIP meetings, American College of Immunization Practice meetings, ACIP. Is that what ACIP stands for? The ACIP meetings have always...
Yeah, it's not the American College, no.
The Advisory Committee?
Advisory Committee on Immunization Practices.
All right, excellent. So ACIP.
Oh, and one other thing, Daniel. One other thing. MMWV is varicella, not vaccinia. Okay, sorry.
Sorry. Thank you. So the chickenpox. Yeah. Thank you. So the ACIP meetings, right? These meetings that are going on right now, have always been treated by the press and the public as sincere efforts to present and discuss vaccine-related information in a public forum. But what happens when the exercise isn't genuine and is instead ideological? When it's vaccine policy theater with the outcome already decided instead of a scientific discussion? So that's the question that CIDRAP is asking. And there were a number of points that they, and I'll leave a link into the CIDRAP piece. But they do point out that VAERS data do not prove causation, right? And they sort of say, think of this as a screening tool, not a confirmatory test. Like this, they use the analogy of the screening mammograms. So we see things in VAERS, and we compare this to what happens in what I refer to as the NVAERS, so they're like not in VAERS, all the things that happen not in the database. And people remain mortal. So people will die after getting a vaccine. People get in car accidents. People will make bad decisions. And we look to see if there is a higher or lower rate than what we see in VAERS compared to those not in VAERS or sort of NVAERS. So that's the first thing. Like, you can't look at VAERS and say, look, vaccine, and then this bad thing happened, because bad things happen. Two, all evidence isn't created equal. So you can't just cherry pick your anecdotes without any scientific rigor. You can't just say this is the same as peer-reviewed, vetted information. And then three, they point out, because we're going to hear a lot, is that serious adverse reactions to the mRNA COVID vaccines remain very rare for kids, pregnant women, and everyone else. And the Vaccine Integrity Project is working with a team of experts, recently screened the most recent literature, consisting of more than 17,000 scientific abstracts, reviewed 1,406 full articles, extracted detailed data from 509 studies, published since the last CDC review of COVID, RSV, and flu immunization literature, and they found no significantly elevated safety risks. I'll leave a link in there to the Vaccine Integrity.
Danielle, we should just remind people that VAERS is the Vaccine Adverse Events Reporting System.
Yep. It is. It's terrible how many acronyms we use, right? I think I'm going to start trying to spell everything out. Yeah, just to make sure. Because that's what it is. Like, someone gets a vaccine, something bad happens afterwards, we report it. We don't know if it's causal. And then we find out afterwards, like, hey, are we seeing this more often? Like when we were seeing the clotting with the J&J vaccine, it was like 6 cases, but we detected that. That was not something you see generally. There was a smoking gun as far as timing. We picked those things up. The Guillain-Barré with some of our vaccines that we see, febrile seizures, right? I mean, there's certain things we start to see, and then we find out there's a connection. But you can't just say, "Oh, this happened after the vaccine." Our internet went down, and there were some of those guys were out, blowing leaves, and my wife was like, "I was right after the leaf blowers." I was like, "I'm not sure that the leaf blowers destroyed your internet here." But it happened right while they were blowing the leaves. Okay, yes. So
that's a good
when
example.
I get it sorted,
I'll
let you know. All right. So let's jump into Chagas disease. It's very appropriate because we're getting some emails about this. And then we get the MMWR report. Chagas disease, an endemic disease in the United States, Chagas disease, or American trypanosomiasis, is caused by a parasitic protozoan, Trypanosoma cruzi, which is transmitted through congenital, oral, and vector-borne routes. Vector-borne infections result from contact with the feces of infected triatomine insects. Kissing bugs. Do you want to give us the proper pronunciation? Reduvid bugs.
Reduvido.
Okay. Now, in the United States, these bugs are commonly found or called kissing bugs. The blood-sucking insects occur naturally in the southern half of the country. They've been found in 32 states. There's a bunch of different species. So there's 11 species found in the U.S. 9 have been found to be naturally infected with T. cruzii. Of these, there are 4 species commonly found in human dwellings. So there's this whole concern. They're here, they got the parasites, they're around the humans, and numerous investigations have revealed that these kissing bugs harbor the T. cruzii parasites, really 30 to 50%. So a lot of them are infected. Certain of these kissing bugs have the largest overall distribution within the U.S., and one particular one appears to be the most common species in domestic settings in Texas and is likely responsible for transmission resulting in locally acquired T. cruzii, Chagas, in dogs and humans. And autochthonous, like so these are cases, human cases here in the U.S. You didn't travel, you got it here. They've been identified already in 8 states. So we're already seeing this: California, Arizona, Texas, Tennessee, Louisiana, Missouri, Mississippi, and Arkansas. They did this whole review. They found 29 confirmed, 47 suspected cases of locally acquired Chagas disease over this 2000 to 2018 period. They say this likely greatly underrepresents the number of human infections. Now, this sort of hit close to home, this next. There's this narrative, and I know I've fallen into this, where we talk about the fact that, well, the kissing bugs in the U.S. are a little different from the kissing bugs elsewhere. Because what happens is you don't actually get the parasite from being bitten by the bug. You get the parasite because you get a bite wound. And then while the bug is feeding on the blood, it defecates at the same time. And it's the feces that either gets into the wound or gets into your eye, you rub it into your eye. And we've always said, like, one of the things about these North American vectors is a post-feeding defecation, that there's a delay, that it's longer. And they're basically saying, you know what, that's hokey. That's not really an issue. And so they're basically saying that narrative has suggested we don't need to worry, and obviously we do. So really what they were basically saying is all this evidence justifies recognizing that Chagas disease is endemic to the United States. Okay. All right. And we will move into Ebola. I think we got a little bit of a delay in our network connection there. So Ebola in the DRC, and a little kudos because I feel like Vincent, you are preempting us here on this, but Ebola in the DRC, Ebola vaccination begins in the DRC. And this was brought up before. Hey, what about ring vaccination? Wouldn't that make sense? Well, from the WHO, we read that vaccination of frontline health workers and contacts of people infected with Ebola virus disease have begun in the DRC. An initial 400 doses of the Ervebo Ebola vaccine from the country's stockpile of 2,000 doses have been delivered to the local area. Additional doses will be delivered. And the vaccine is being administered, yes, through ring vaccination strategy. And this entails, what is this? Vaccinating individuals at highest risk of infection after having come into contact with a patient confirmed with the virus. Also recommended for healthcare, frontline workers responding to the outbreak. The nice thing is we have vaccines. The Ervebo vaccine is safe, protects against the Zaire Ebola virus species, which has been confirmed. That's the Ebola virus species we're seeing here. We've got more vaccines on the way. The International Coordinating Group on Vaccine Provision has approved around 45,000 additional vaccine doses that are going to be shipped to the DRC. In addition, they also got treatment. So in addition to vaccines, we have treatment with a monoclonal antibody, MAB-114. This is being sent to treatment centers for clinical care. And on the ground, the WHO has so far deployed 48 experts in disease surveillance, clinical care, infection prevention control, logistics, community engagement, who along with partner organizations are supporting the government to rapidly strengthen outbreak response measures to halt the spread of the virus. All right, so lots of good stuff going on there. I'm encouraged. Not so good stuff when it comes to measles. And this was a question that was asked while I was speaking up in Maine recently. And first part of my talk, I was covering measles. And this issue about a sort of a later complication, subacute sclerosing panencephalitis, as opposed to the acute encephalitis. And we hear that an LA child dies from complications of measles infection contracted in infancy. So here we are later, after the child had survived the initial infection and developed subacute sclerosing panencephalitis, a fatal progressive brain disorder that typically develops 2 to 10 years after initial infection, even when, as in this child's case, the patient recovers fully from measles. The disease begins with seizures, cognitive decline, involuntary muscle spasms, progresses to dementia, coma, eventual death. This baby acquired the measles infection prior to being old enough to get their measles vaccination. And this is really this example we talk about. Very young babies rely on antibodies acquired during gestation, and herd immunity to protect them from measles. They really rely on the rest of us to keep them safe. So, a couple concerns. One is think of all the children that are getting measles. We'll get to this number approaching 1,500 in the U.S. Even if they survive the acute period, there's that immune issue that happens for 2 to 3 years afterwards, and then even these late complications that we can see. We also have the research letter tracking county-level measles cases in the U.S., published in JAMA. I think some of our listeners will be familiar with this. But let's a little background they start with. So prior to the introduction of the measles vaccine, you ready for this? More than 90% of U.S. residents were infected with the measles virus before the age of 15, with 3 million to 4 million annual cases of measles, resulting in approximately 48,000 hospitalizations. And this was when we were less of us here in the U.S. Now, building on their experience with timely infectious disease surveillance through the Johns Hopkins University COVID-19 dashboard, this group developed an infrastructure to track confirmed measles cases as they are publicly reported across all affected counties in the U.S. So going to leave in the link to the article, but yeah, this is the Johns Hopkins U.S. Measles Tracker. So if we feel like we're not sure about what's going on as far as number of cases from the CDC, we've got this independent organization tracking the measles cases. And where are we? Basically, we are approaching 1,500. So as of September 16th, there were a total of 1,491 confirmed measles cases reported in the United States. Up there in Canada, they are approaching 5,000, another 53 new measles cases, and now a total of 4,902 up in Canada.
So, Daniel, as the number of measles cases increases, the likelihood that you will see more SSPE in the future does, because you get about 10 cases per 100,000, 10 cases of SSPE per 100,000 measles. And, in the heyday before vaccination, there were a lot of cases of SSPE because there were millions of measles cases. Now, we're not there yet, but if things go badly, we could start seeing a lot of SSPE again.
Yeah, I mean, that number works out to about, 1 per 10,000 or so, somewhere in the 1,000 one. But it does actually matter. The number varies based upon whether you're vaccinated or not, right? So seeing all these cases, particularly in unvaccinated folks, we're starting to get to the point where in coming years, we're going to start to see these pop up periodically. And really a horrible thing. It's been a number of years since I've seen a case personally. Horrible. I mean, it just, sort of as I went through the discussion about what we actually see, I'm going to go back to that. How do these little kids present? Basically progressive brain issues, seizures, cognitive decline, muscle spasms. It progresses in a baby to dementia, coma, eventually death, right? So really horrible outcome that can be vaccine preventable. All right, flu. People are starting to think about getting those flu shots, and we are up to 280 flu-associated pediatric deaths from the last season. So we just keep getting a few more confirmed as they go through. 280 children that died of flu, right? So, and we have an article. I got an email, Dr. Griffin, how could you not have covered this last week? Well, we're covering it this week. We're going to cover it here and on podcast. The article, Efficacy of Baloxavir Treatment in Preventing Transmission of Influenza, published in the New England Journal of Medicine. This is a situation, someone, around you has the flu, or maybe you got the flu and you don't want to give it to people around you. So this is a multi-country phase 3B trial to assess the efficacy of single-dose baloxavir treatment to reduce influenza transmission from index patients to household contacts. Influenza-positive index patients 5 to 64 years of age randomly assigned in a 1-to-1 ratio to get baloxavir or placebo within 48 hours after symptom onset. Primary endpoint was transmission of flu from an index patient to a household contact by day 5. And the first secondary endpoint was transmission of influenza virus by day 5 with symptoms. So overall, we've got 1,457 index patients. These are the folks that have the flu, that are either going to get baloxavir 726 or 731 get placebo. We've got 2,681 household contacts. By day 5, transmission was significantly lower with baloxavir than placebo, so 9.5 versus 13.4. The emergence of drug-resistant viruses during follow-up occurred in 7.2% to 11.6% of the index patients in the baloxavir group. Now, interesting, no resistant viruses were detected in household contacts, and I think that's really relevant, and no safety signals. So, getting that baloxavir, it may help you do better, and it may also reduce your risk of transmitting it to others. All right, RSV. So, we'll keep an eye because usually October is when we start to see the signal down in the southeast U.S. We do have the vaccines, we have the monoclonals. So we do have the tools. I'm very excited to see how we do this year. But the most exciting part of our show, Vincent, looking at the SARS-CoV-2 wastewater curves. Does that bring you as much joy as it brings me, just knowing that this information is out there?
Yeah, I think it's great that we
see a
have
lot of
this
joy
information. There. Yeah. I heard a talk at this meeting by someone who was doing swabs of elevators, and that the results match the New York City wastewater surveys. And so the person said, in case that public health, just theoretically, public health is destroyed in the U.S., we could do our own environmental sampling for respiratory viruses.
Yeah, we can. That's great. And unfortunately, as you're seeing, yes, we are on our way to the moon. So I was in the doctor's lounge yesterday, and one of the doctors, Dr. Perlman, he's like, "Hey, you guys, what's going on? Is there some kind of COVID uptick?" I'm like, "Yes, Daryl, there are lots of COVID cases. Yes, we are research." And I told him all about what we do wastewater.
Was he a surgeon or something?
So, yeah, this matches me.
For a cardiologist?
No, he's a hospitalist. So he's a hospitalist. So he's just seeing a lot of COVID cases. And he's like, hey, suddenly we've got a lot of folks in the hospital with COVID. So it matches. It's nice when the experience matches what we're seeing. But the levels are pretty darn high here. I mean, the South, we're already higher than we were during the winter surge for those guys. We're basically where we were for the winter surge when you look at, the national numbers. We'll see what happens with the Northeast. We had pretty bad surge last winter, so we'll see what happens. But yeah, lots of SARS-CoV-2 in the wastewater. All right, well, active vaccination, right? We've got some choices. We've Pfizer's, we've got a couple Moderna options, we've got Novavax. Last week, we talked about some Pfizer BioNTech data. This week, Moderna, maybe next week, Novavax. We have a press release, and this is Moderna announces updated COVID-19 vaccine against LP.8.1 variant generates strong immune response in humans. Moderna announces positive preliminary immunogenicity data for the 2015-2026 formula of Spikevax, which targets the LP.8.1 variant of SARS-CoV-2 to help prevent COVID-19. The data is from an ongoing phase 4 clinical trial evaluating the safety, tolerability, and immunogenicity of the 2025-2026 Spikevax. And it really showed, on average, a greater than 8-fold increase in neutralizing antibodies. Safety profile was consistent with prior studies. I should ask you, Vincent. You got a COVID shot recently. Was it Spikevax? Was it the next spike? What did you get?
I got an mRNA vaccine, but I don't know which one it was. They didn't say.
Okay. All right. Yeah, I'm kind of curious what's gonna happen when I try to get my vaccines next month. We might do it as a family when the kids come home from college. So, here we have the article Adverse Events Associated with COVID-19 Vaccination or Diagnosis Among Pregnant and Non-Pregnant Women in the United States, 2021-2022, published in International Journal of Infectious Disease. And, I say carefully selected anecdotes versus real information. So as we're hearing lots of anecdotes to support an agenda, what's the actual science? how safe are these vaccines in pregnant, non-pregnant women? So here we have real science. It's a cohort of over 1 million women, not just a few stories, carefully cherry-picked, looking from 11 December 2020 to 30 September 2022 in the U.S. They identified 3,556 adverse events among pregnant women with near identical incidence rates between those unvaccinated and vaccinated. So just really want to point out another study reinforcing the safety of COVID-19 vaccination in pregnant women. But the other side, what about what happens when these pregnant ladies go ahead and get a COVID-19 diagnosis? Things don't go well when you compare, the pregnant individuals to non-pregnant. So if you're pregnant versus non-pregnant, pericarditis, an adjusted odds ratio of 5.35, so over a fivefold increase in getting pericarditis. Having an acute myocardial infarction, right? Think of this demographic. We are seeing a tripling of MIs in the pregnant ladies when they get COVID, just really reinforcing also the significant increased risk with COVID-19 during pregnancy, sort of factoring that in when we make recommendations about vaccination. All right, we've got a fun article here in the COVID early viral phase, right? So you test positive. Those at risk of progression still have the recommendations for the early use of antivirals. But here we have a blast from the past, so to speak, rapid elimination of culturable SARS-CoV-2 with intramuscular or intravenous administration of antiviral monoclonal antibody therapy, published in Open Forum Infectious Disease. So one of the big challenges we had here, and we spent a lot of time setting things up, how are we going to get people these antiviral monoclonal antibodies infused? We had pop-up infusion centers. We had EMS setting up, the sort of neighborhood-based infusion centers. Couldn't we just give it IM? If we could just give these shots IM, it would be so much easier. People could just come in, get an IM shot, in the lateral thigh, moving forward. So here the investigators looked at that. They looked at getting an IM, intramuscular, versus IV, intravenous infusion of tixagevimab, silgavimab, so Evusheld, right, in early COVID-19. Following treatment differences between groups became evident. One day after the monoclonal infusion, so day one, SARS-CoV-2 RNA levels were not statistically significant, whether it was IV or IM. But those receiving the monoclonal antibodies were less likely, I love this, to have culture positivity, 6.3% versus 62%. So, if you were just doing RNA levels, hard to see much of a difference. But if you, and was it IV, IM, or even placebo, but if you went ahead and you look for culture positivity, 6.3% versus 62%. On day two, 50% of placebo participants were still culture positive compared to none if you got the monoclonal antibodies. It didn't matter was IV or IM. So IM or IV administration led to rapid elimination of culturable SARS-CoV-2. And as mentioned, this is a huge thing for the future because if we can give IM monoclonals, so much easier to get this out there, get this to patients than if we have to have IV infusion centers.
Daniel, what's the volume that they're injecting IM? Do you know?
It looks like it's a 1.5 ml per dose. So it's significant. It's a big shot. You might end up with like one shot on either side or something. So, all right. Moving on to late phase past long COVID, right? So we moved past the early inflammatory phase where we're seeing a number of folks in the hospital now. Steroids, right time, right patient, pulmonary support, anticoagulation, sometimes antiretrovirals. But then we get into the late phase. I really like this article. It's the article CSF Immune Cell Alterations in Women with Neuropsychiatric Long COVID, published in JID. So here we have 22 women with and 10 women without the NP, the neuropsychiatric long COVID, enrolled from New Haven, Connecticut, and the surrounding region. And they got blood drawn, and they also got large volume lumbar puncture. So really kudos to all the people that went through this. Total RNA was extracted from the cerebral spinal fluid cells and the peripheral blood mononuclear cells. Polyadenylated RNA was sequenced and differential expression analysis were performed. We've probably mentioned the polyadenylation RNA, trying to sort of enrich, I guess, for messenger RNA. Some people might feel like it might be nice to sort of have parallel to this. What about, the non-polyadenylated RNA? But anyway, both CSF and PBMC samples showed differential gene expression associated with long COVID status. And there actually were CSF specific, and this is sort of helpful. Like, what was the point of that large volume CSF? Well, there were CSF specific differentially expressed genes. They give that an acronym, of course, in people with long COVID, including genes related to oxidative stress, reactive oxygen species, P53 response, really indicating that there were compartment-specific immune responses. And some pathways were dysregulated in both CSF and the peripheral blood mononuclear cells of long COVID compared to controls, including those related to androgen response, some mTOR C1 signaling, and lipid metabolism.
So, Daniel, I have a question. Is the CSF normally acellular, and so is the presence of cells here indicative of inflammation?
Yes. So there normally are few cells in the CSF, and we sort of have a threshold of, less than 5 cells per a certain volume. So that's, I think, part of the importance of doing large volume, so you get some cells. But yeah, it is a paucicellular fluid that you extract in general. Now, someone has meningitis, for instance, and then you just see significant numbers of cells. But yeah, it is a paucicellular environment, thus necessitating the large volume lumbar puncture.
So, Daniel, these individuals with NP long COVID, they still have low cells in the CSF, so they don't have an active infection going on, correct?
That all evidence would support that. Yes. Yeah. They do not seem to have, an active infection. They do tend to have some of these changes, they're sort of immune changes. But yeah, that's what it looks like, more of an ongoing immune response rather than an active ongoing infection. And
so is the idea that because there's an ongoing immune response, this is contributing to their symptoms of long COVID, correct?
That's the idea. And I think that's sort of the important idea that, a lot of studies, a lot of people have looked for like replication competent virus in these compartments. We haven't seen that. But what we have seen is evidence like that. There's some sort of disturbance of the immune response that just has not quieted down. All right. Well, so we've been saying for many years now, no one is safe until everyone is safe. So if you're sitting in a safe situation at the moment, think about all the other folks that are not, or just think about all of us sort of together in this crazy world, right? So I'm hoping everyone would pause the recording right here. We do our work because you support us. You allow us to do this. You fund this work. So go to parasiteswithoutborders.com, click on the donate button. Even a small amount helps. We're in the middle of our August, September, October American Society of Tropical Medicine and Hygiene fundraiser. We're going to be doubling your donations. We're hoping to get up to that maximum donation of $20,000 to send that check to ASTM&H.
So just before we get into the letters, I just wanted to make a few comments. I'm here at the European Society for Clinical Virology meeting, and there are very few Americans here, as you might suspect. Usually there are more, but because of budget constraints, there are fewer. But all of the Europeans I've spoken to, and I've spoken to quite a few because we have a lot of TWiV fans here in Europe, all of them are shocked and dismayed about what's happening to public health and science and everything else in the U.S. And what they say is, we always look up to the U.S. for guidance, and now we can't do that anymore. So folks, just think about what these changes are doing to, it's supposedly to make America healthy again, make America great again, but it's doing just the opposite.
Yeah, no, it's a shame. We're losing the respect of the world, and that was not, I don't think, anyone's goal here. So I'm not sure where we've gone so wrong.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Jerry writes, just got this in an email. Applies to all regions served by Kaiser Permanente. I was looking through the FAQ, and it seems like they're giving Moderna for 4-year-old and younger, Pfizer for 5 years old and up. No prescription required, no comorbidities required, no cost for the vaccine, provided you get it at a Kaiser center. I'm in the Mid-Atlantic region, got my flu shot, will schedule my COVID. Up to date on everything else. Thank you both for all you do. Thought you might get a small happy from seeing science win at Kaiser Permanente. And she sent an email from Kaiser saying the COVID vaccine will be available at no cost for Kaiser Permanente members 6 months and older beginning September 15th. And so they did their own review and decided that people should be able to get COVID vaccines.
Yeah, that's fantastic. And, that's sort of in line, and I think maybe a little bit forward looking compared to the approvals, right? So the approvals for Pfizer was, 5 through 64, 65 and up, and then they add certain, limitations. Moderna was actually approved individuals 6 months through 64. So, I think that makes sense how they're putting that all together. I really applaud Kaiser for that move. So fantastic.
Linda writes, thank you for keeping us informed of the true science versus politics in healthcare. I listen every Saturday through YouTube. I have terrible seasonal allergies, so I'm wondering if antihistamines reduce the effectiveness of flu and COVID vaccines. Is there any research on it? Last fall, I waited until the end of October before getting them. However, my granddaughter just had COVID this past week, so perhaps as a 69-year-old, I need to get them earlier this year. Just an FYI, there are currently 21 cases of Legionnaires in Marshall County, Iowa. So far, no results in searching for the cause, 1 death so far.
Wow, Linda. So, it was amazing, like the amount of science we got around the COVID vaccines and all kinds of, antihistamine, should you not? Is there a significant impact of antihistamines or not? There is some research on that. In general, some people might take a little time off from the antihistamines, just sort of the thinking that, it's something that impacts the immune system. But a lot of it has to do with how bad are your allergies? Is that a big lift? You say you have terrible seasonal allergies. I'm not sure you need to suffer miserably to get, a marginal, if any, impact on your vaccination efficacy. The other is really a challenge, right? I mean, we talk about RSV, we talk about flu, we have a certain sense of timing. But what about COVID? What about, circulation of the SARS-CoV-2 virus? Now we're seeing higher levels in certain parts of the country than we saw last January, and we're in September. So it's really hard to predict. We're talking about an early winter. We've been trying to sort of peg when is a good time to get those COVID vaccines, and so sometime probably early October, somewhere in October probably makes sense. But again, we're trying to predict the future, which is always a challenge. And Legionnaires, there's so much in this email. Here we are in September. We just had another admission to the ICU. Another case of Legionnaire's disease, so Legionella pneumonia. And a lot of it it's that time of year. It's September, got accumulation of the water in the air conditioners. There's the paramecium, the amoeba with the intracellular Legionella bacteria. You breathe it in from the water vapor. They'll do the search. But, if you're still using those units, one last cleaning. Let's try to keep things so that we're not having these cases.
Beth writes, I'm wondering about getting my next COVID booster earlier than 6 months after my last one. I'm 72 and got my last booster in May. If my math is correct, that means my next shot is November. Is there any reason I can't get it earlier, say in October? I'll be traveling to Peru in late October, would like to be protected. Also, I'm worried that the vaccine may not be available if I wait. It seems that many people are rushing to get the vaccine now in September, and I've heard that there may be new recommendations restricting it to those over 75.
Yeah, so Beth, it's crazy times, right? That you're worried that someone is going to take away your access to vaccines. And there have been a number of articles. Part of decisions people are making. What state do I live in? How good is my state going to be at maintaining access for me? There's no problem with doing it a little bit early. And if you're going to go to Peru late October, you want to get this at the beginning of October. It's sort of wait at least more than 3 months after you've had a vaccine or an infection, 3 to 6 months. Unfortunately, we're seeing that this boost that we get tends to sort of wane after about 6 months. So no problem I'm seeing with you getting it early October.
Sue writes, let me be the 31st person to excitedly email you with the news of the press release yesterday, September 16th, from the American Insurance Trade Group, ACIP, who announced the intention of 1,300 of their member companies to cover vaccines based on ACIP recommendations as of September 1st, 2025 through the end of 2026, with no cost sharing for patients. The recent events are gliding into one for me lately. Does that window, September 1st and prior, take us back to the old regime of everyone 6 months plus eligible for COVID-19 vaccine? Looking forward to clinical update as usual late Friday. Right as I'm teetering on despair, your smiling faces and sensible words can be remarkably soothing, even when you all are angrily complaining about stuff I'd perhaps already filed to the back of the line of horrible news. Must be the magic of bedside manner. I don't have any bedside manner. It's Daniel.
Well, thank you for the kind, email, Sue, and the update. This is great. The science-based recommendations, right, was for everyone 6 months up to go ahead and get a shot once a year. For those 65 and above or higher risk individuals, doing maybe that every 6 months. So hopefully we're going to have science-based access at least. I mean, I was talking with my daughter Daisy's boyfriend, John Scott, earlier today. The CDC is supposed to provide us with guidance. They're not a police organization. There's no mandates there. And as Sid Rapp was saying, we were expecting to hear a science-based, honest discussion. And then we could base the recommendations and our decisions on the science, the available information. So appreciate all these updates from you.
It seems to me, Daniel, that if they're going to go by ACIP September 1, that's before the changes were made, right?
Yeah, before the craziness. Yeah.
Yeah. Marshall writes, first, thank you to both you and Vincent for continuing to be a wealth of reliable information in this very challenging, nay, insane political climate. I have two related questions about the treatment of solid organ transplant in patients with a SARS-CoV-2 infection. First, I recall early in the pandemic seeing publications indicating that as many as 30% of diagnosed transplant patients go on to be hospitalized. Are you aware of any further studies or what the actual rate progression is in these patients? Secondly, for these patients, is IV remdesivir still the recommended therapy option, and is it still believed to be effective in this patient subpopulation? I have seen conflicting reports. For context, my mother, 74 and recovering from a stroke, was diagnosed yesterday with SARS-CoV-2 infection, her first that we are aware of, and she is immune suppressed for a kidney transplant that she received nearly 10 years ago. Her doctor is recommending a wait and see approach, eye roll, and has previously been resistant to putting her on PEMGARDA as a preventative. Thank you so much for your guidance.
Ouch. So, let's talk about the recommendations. So the first is people with transplants, so organ transplant patients, certainly are at increased risk of progression. 20-30% we're seeing progress. So this whole wait and see is not recommended. That's not in line with any of the guidelines on how these folks are treated. Up front, PEMGARDA would have made sense in this population. Sometimes there are some access issues, but it sounds like this was a recommendation issue, not actually an access issue. The other is, so IV remdesivir. So how do you approach a transplant patient? So one of the biggest challenges could be polypharmacy, can be issues with drug interactions, right? Because it's very easy to go ahead and do an outpatient treatment with Paxlovid, so the nirmatrelvir or ritonavir. But a lot of times you're going to run into the cytochrome P450 drug-drug interactions, which is why we think of things like IV remdesivir. And it's a 3-day, right? It's 200 milligrams the first day and then 100 the next couple of days. We've continued to see that, even with current circulating variants, even with the vaccines, right? That this is still recommended that we do early treatment. So wait and see is not really in line with the science, not really in line with what's being recommended.
And Yana writes, thank you for everything that you and Vincent do to keep us all up to date and informed. I'm not sure if there's a way to search the episodes or not, so I'll ask this question. A few months ago, someone wrote in, I think a retired doctor, asking more about getting Paxlovid without paying $1,500 to $2,000. I can't remember if you had any suggestion other than Paxess. My good friend has caught COVID. She's avoided it for 5 years. I told her to get a prescription right away, but when she called the pharmacy, they told her it's $1,500. She and her husband are both retired and not in the best situation to pay full price. She's on Medicare, but does not have Part D. She was told she needed to have Part D to qualify. Is there any other program for Paxlovid? Any information you can give would be greatly appreciated.
Yeah. No, so most folks, I've been sending them to the Paxess and then going through that. We just had recently that this came up, and it's a great approach to it. You also might consider doing like a GoodRx and seeing if that helps as well. But no, this is a challenge, and we've talked about this when people. And I'm going to do it right now. I'm going to look at Paxlovid in the GoodRx and see if it gives me a. No, I'm not seeing that they're helping me out too much. So yeah, no, the Paxess is a great approach.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.